What's up, everybody? My name is Dr. Garrett Rossi. I am a board-certified psychiatrist, and I make mental health content here on YouTube. So if you're new to this channel, it really helps me to know that you guys are getting something valuable from it, so please consider subscribing. And if you're a returning viewer, thank you so much for your support. I'm always excited to talk about psychiatry, but I'm really excited to talk about this topic today because I think it's going to blow your mind. And the reason I say that is because I'm going to go against most of the conventional wisdom associated with this particular disorder, and I'm going to explain why I'm going against the majority of the conventional wisdom associated with it. And before I even start this video, I want to apologize for the things I'm going to say to my child adolescent friends who either are in fellowship, graduated fellowship, practicing child psychiatrists, because they've devoted most of their lives to treating this disorder. And so you might already have guessed it, but what we're going to be talking about today is ADHD, attention deficit hyperactivity disorder. And we're going to be asking a really important question. Is this even a real psychiatric disorder? And I think what we have here today is going to blow your mind. So stay tuned and check it out in the next clip. Okay guys, so I want to start our discussion by kind of framing things a little bit. Now, ADHD in the adult population has been a topic of great debate for a long time. Now, there are many psychiatrists who will say to you that ADHD symptoms do not suddenly disappear when a person continues into adulthood. And then there's other psychiatrists, which would probably be the minority, but there's other psychiatrists out there who will say something like, there really is no basis for an ADHD diagnosis because it can be explained by other factors. And we're going to talk about all those things in the video. So we got two different camps here. I would say the vast majority of psychiatrists you encounter are the ones who are going to say that, well, it's a proven fact. ADHD symptoms continue into adulthood and need to be addressed. And then you have a minority of psychiatrists who are going to say that, maybe we got to pump the brakes on this diagnosis and reconsider things a little bit. So let's break it down a little bit further. The term ADHD might be better thought of in the adult population as ADD. So eliminate the hyperactivity portion because this concept of hyperactivity is more common in the child adolescent patient population. It's really not seen in the adult population with ADHD diagnosis. Now, it's unclear if the hyperactivity, even in children, is related to the executive dysfunction, which is the hallmark of ADHD. It may be that this hyperactivity is within the range of normal, right? And I'll explain that in a second. So this could be things like agitation or activation. Now, it could also be possible that these inattentive symptoms and this hyperactivity is the result of another disorder. Could be a mood disorder such as bipolar illness, right? And this is especially true in our adult population where the bipolar diagnosis is commonly reserved. So we can make an argument here. We can make an argument that when you place children in a traditional school setting where they are asked to sit and pay attention to often boring, uninteresting material for 7 hours a day, that is an unnatural state. That is not the way humans are meant to learn and interact with their environment. So this is directly against the ways that humans evolved to function, both brain and body, right? The human body and mind evolved to move, to be active, not to sit in classrooms, read books, learn boring information, memorize categories, etc., right? So as a result, things like agitation, hyperactivity, and acting out could just be the result of this unnatural state that we're forcing children into and even adult learners into. And the hallmark of ADHD, like I said, is really attentional impairment and executive dysfunction, right? Hyperactivity is not commonly seen in the adult populations. And we're going to talk more about attention as a trait in the next section. In this section, I'm going to talk about attention as a trait. Now, we all have a certain amount of attentional capacity, right? And there's going to be variations in the population between individuals. Let's take, for example, attention and think of it in the same manner we think of blood pressure readings, right? We're going to medicine this up a little bit, make it more medical for you guys. So there is a mean blood pressure in the population, right? But we know that there will be individuals that are going to fall outside of that mean. Either they're going to have really high, say, blood pressure readings, and then we know that there's going to be individuals that are going to fall in the opposite spectrum and have really low blood pressure readings for whatever reason, right? Could be pathology, could be natural, right? Some people run low when it comes to their blood pressure. But essentially what we're talking about is we're going to have sort of like a normal bell-shaped distribution or curve, and then we're going to have some individuals on one side or the other that are falling outside that standard range. Now, most people in the population are going to fall right in the middle. They're going to have a reasonable amount of attention, right? They're going to fall somewhere in the middle. They become inattentive at times, especially if things are boring and unstimulating. And at other points, they're going to have very highly focused attention depending on what's going on. So they have like an in-between mean amount of attention, okay? Now, what we can say here is that those with low attention levels do not necessarily have a disease, okay? So it's not necessarily a disease to have a lower level of attention as a trait. Now, the consequences, though, associated with low levels of attention can be very real, right? These consequences of reduced attentional activity can cause problems for people. And when somebody is on the opposite end of the spectrum, say they're not low in attention, but they're too attentive, they're overly attentive, this can be seen in symptoms of disorders like obsessive compulsive disorder. The person is too focused on these things and having difficulty with these obsessional thoughts despite the fact that they don't want to really be thinking about these things. And also things like psychosis can also have over-attention. This is the so-called, internal preoccupation or responding to internal stimuli. It's where I'm overly attentive to what's going on out there, whether it be delusions or perceptions that are altered. So like blood pressure, having readings that are too high or too low can cause problems. And it's normal to have a certain amount of inattention. We have to understand and we have to normalize some of this because we're not always 100% attentive. And again, you stick someone in an unnatural environment like a classroom and their attention levels may go down. So we can think of attention as a spectrum with a range of normal values. In this section, I want to brainstorm with you guys for a second about potential causes of inattention. What are things that can cause us to be inattentive? Well, one possibility is it's perfectly normal. It's a perfectly normal trait. As we explained, some people have low attention spans naturally as a personality trait. So that's one possibility. This is just within the range of normal. Another big possibility, especially in adult populations, is that there's a comorbid mood disorder, right? Mood disorders like depression and bipolar disorder have inattention as a possible consequence or symptom from the change in mood. Also, psychotic disorders. Psychotic disorders also have cognitive changes associated with them. In many cases, the cognitive symptoms of schizophrenia are the ones that cause the most impairment. So you can have changes that cause inattention, such as I described in the last section, internal preoccupation. Another possibility is that it's the result of an anxiety disorder. Anxiety can certainly cause cognitive dysfunction and it can certainly cause inattention, because you're so focused on being anxious that you can't possibly focus on anything else that's going on around you. Another possibility is that these are neurocognitive disorders. Neurocognitive disorders as a result of many different medical conditions. Could be a traumatic brain injury, could be a seizure disorder, could be Alzheimer's disease or another dementia, right? Lewy body dementia, frontotemporal dementias, etc., etc. So we should avoid diagnosing ADD in the setting of one of these other conditions because it's quite possible that the ADD symptoms are really just the result of one of these other consequences or one of these other disorders. Let's talk about the prevalence of ADHD in the United States. Now, the prevalence of ADHD in the United States has a great range. So the range is anywhere from 5.6% to 15.9%. And there is great variability, wait for it, depending on the geographic region you live. So that's interesting, right? Why is there so much variability? Because when we think about a disease like ADHD that is said to be very biological, we really should see similar prevalence rates across populations and geographic regions. It shouldn't change much because we're saying this is a very genetic disorder, and so there shouldn't be much change across populations or geographic regions. For example, when we think of schizophrenia, it has a prevalence about 1% worldwide, and that doesn't change very much. You might say, oh, it's more like 0.8%. In some places, it's a little higher than 1%, but it's right around 1%, and it stays very, very consistent. Not a range of 5.6% to 15.9%. So why do we see significant differences across the United States? Well, one thing I can say is we don't know very much about the role of socioeconomic factors, things like diet, exercise, and social factors, and what role they play in the development of ADHD. There's not a whole lot of good research in that area right now, so that is one possibility, is that things like socioeconomic factors, and when you look at the map, you can see that a lot of the states that tend to have higher prevalence rates of ADHD also have lower socioeconomic status. So that's concerning. There's some factor there. Now again, correlation, not causation necessarily, but the part that's kind of frightening is we really just don't know anything about this. So that's concerning. It's possible that these are contributing factors to the symptoms of ADHD and we just simply don't know much about it. Okay guys, so is ADHD a neurodevelopmental issue? And I'm going to make a case that it is a neurodevelopmental issue, and I'm going to explain why. So one way of thinking about ADHD here is as neurodevelopmental problem that eventually improves over time. Because one thing you'll hear from all ADHD experts is that the symptoms tend to improve as people age. So as you get older, those symptoms tend to get better. Some, like inattentiveness, can persist, but we'll get to that in a second. Now, in children with ADHD, they seem to achieve peak cortical thickness later than children without ADHD. And this has been proven and confirmed on imaging studies and tells us that peak cortical thickness, so the development of the cortex, specifically the prefrontal cortex, takes more time to develop in somebody with ADHD than somebody who doesn't have it. The important part that I want to stress to you guys is that these children eventually catch up to their normal controls. It just takes more time. And that delay is roughly about 2 years. So they're delayed about 2 years behind the development of normal controls. So it's more of a delay in brain development than a permanent state that can't be altered or that requires continuous treatment and medication. The ADHD children are 2 years behind the normal controls, and the area of greatest delay is the prefrontal cortex, which makes a lot of sense since we know it's responsible for executive function. So this delay, the symptoms, and the problems associated with executive function make a lot of sense in this context. Now let's try to talk a little bit about how common ADHD is in the adult population. And also, does it last into adulthood? Do we have evidence to really say for sure that these symptoms last? And I'm going to tell you some mind-blowing stuff in this part because I think this is where it really starts to get interesting. Over the past decade, ADHD in the adult populations has gotten a lot of attention, right? There's more prescriptions being written for ADHD medications in adult populations than ever before. Some would say that the prevalence of adults with ADHD is somewhere around 4% to 5%. With equal rates being seen in men and women. So that's the common way of thinking about adult ADHD in terms of prevalence and breakdown. However, the National Comorbidity Service estimated that 46% of children with ADHD have symptoms that persist into adulthood. And I'm going to tell you why that number is inflated in a second. So that's a very large amount. It's almost 50% of the people diagnosed ADHD as children are going to persist into adulthood. One problem with this national comorbidity survey and this 46% number is that many of these individuals had comorbid psychiatric disorders. So like I said before, could it be that some of these symptoms, or maybe even all of these symptoms, are explained away by another psychiatric disorder? And many of these individuals in that particular study had comorbid anxiety disorders, and we know that anxiety can be a major cause of inattention and executive dysfunction. Now, other studies have found similar things, so their similar findings were reported. What stands out to me in all of these studies that cite this very high rate of continued ADHD symptoms into adulthood is that there's always high rates of psychiatric comorbidity. So they don't account for, in these studies, they do not account for comorbid mood disorders, including depression and bipolar disorder. Now, of course, it's possible to have ADHD and depression and bipolar disorder, but you can see how muddy this can get and how difficult it can be to discern when the symptoms overlap so greatly. So it's hard to make a diagnosis of adult ADHD in the presence of a condition like bipolar disorder or major depression. Considering that overlap, right? Considering that symptom overlap, and the known cognitive dysfunction associated with mood disorders. So it's possible that the mood disorders, the anxiety disorders, can account for most of ADHD cases and variations of the normal trait, right? People, again, who are normally less attentive than, say, the average person in the population, that could potentially explain the rest of these ADHD cases in adulthood. Looking at things like medication response, some people will say, well, how do you explain the fact that when I take stimulants, I'm doing better? Well, that's easy, right? If I took stimulants, I would be doing better. If anyone took stimulants, their attention would increase, their focus would increase, their work capacity to sit at their desk and do what needs to be done or sit in their classroom and work harder, take their tests more efficiently, would all get better. It gets better in everybody. So looking at the response doesn't really help us much because amphetamines are helpful for everyone. It would make everybody perform better. That's why people use them as performance enhancing drugs. So we could think of, like I said, our college student taking midterm exams, they're going to perform better on those exams potentially as a result of amphetamine use because they just have more capacity to sit and work longer. When you correct in these studies for comorbidities, right? When you actually correct the percentages for comorbidities in adult ADHD, only about half of young adults meeting criteria for ADHD had ADHD only. It's only 50% of those people who had adult ADHD only had ADHD and no other psychiatric diagnosis. Estimates from this showed that most children diagnosed with ADHD were no longer meeting criteria in adulthood. When you actually correct this all out, what you find is that 83% of children who had ADHD as a child do not have it as an adult, right? So majority do not meet criteria for adult ADHD. And many of those people in these studies who were considered newly diagnosed cases of ADHD, meaning that these were individuals who did not have ADHD as children. 87% did not have ADHD as children. These were adults who were diagnosed with ADHD much later. So what this tells me, in conclusion, to kind of sum it all up, is that this indicates that 46% number that's initially cited, that's often stated by other doctors and psychiatrists and child adolescent psychiatrists, indicates to me that it's actually a much lower number. Probably somewhere around 17 to 20%. Let's just call it 20% for the sake of argument. It indicates to me that about 20% of children diagnosed with ADHD will have symptoms persist into adulthood, but the vast majority, 80%, will not. And that's very important to understand. So what about medications in ADHD, especially adult ADHD? The prescribing practices for adult ADHD have changed vastly since the mid-1990s. So when we look at prescribing practices from the mid-1990s to now, there's a significant increase in amphetamine and stimulant prescriptions for adult ADHD. You might be saying, well, that's just because we're recognizing it better and it's a bigger problem and we need to work on it. But this has led to one of the more disturbing trends in psychiatry in my mind, and that is the use of amphetamines in people with psychotic disorders. This is one of those psychopharmacology rules that we should really abide by as psychiatrists, and that is, do not prescribe amphetamines to people with psychotic disorders. It usually makes them worse, right? This has been my experience clinically. I'd say that this is a vast majority of the cases. And maybe in very, very rare instances where you've tried everything else and nothing seems to work, you may consider it in patients with schizophrenia because there was some evidence kind of saying it does help. And like I said, amphetamines will help anybody with some of those executive and cognitive dysfunction. But for the most part, what I've seen when individuals diagnosed with schizophrenia, schizoaffective disorder, even bipolar disorder, have, especially those who have had psychotic features in the past, are prescribed amphetamines or other stimulants, it makes them worse. They develop psychosis and then they come to the hospital and they need treatment. But like I said, interestingly, there was one study that looked at schizophrenia and they looked at patients who were stabilized on an antipsychotic first and then added a stimulant to improve cognitive function. There were improvements in certain types of cognitive functions, specifically spatial working memory, language production, and working memory accuracy. So there was some improvement there, even though, again, I think the vast majority of these cases would tell us that stimulants do more harm than good, and there's certainly not enough evidence to recommend stimulant use in all patients with schizophrenia just because it does improve some small aspects of their executive functioning. And again, maybe it would be considered in very rare cases. I have seen it done. Another important point to make here is that in animal models, it has been well established that amphetamines have been shown to have some dangerous effects. So you can't necessarily say animals are the same as humans, and you can't, extrapolate all that information, but it is concerning to know that in rats and mice and such, that there are concerns. And some of those things are decreased response to reward stimuli. So changing the way our reward system works, which can lead to things like addiction. Increased anxiety. Stimulants like caffeine, if you take a lot of caffeine, right, you can have increased anxiety, and these type of stimulants as well. Obviously, increased anxiety is a possibility. Decreased dopamine activity. So because these medications are primarily working on the dopamine neurotransmitter, you can have changes in your basal levels, you can have changes in dopamine neurotransmission in general. And then the most concerning to me, the one that stands out in my mind, is decreased long-term survival of new neuronal cells in the hippocampus. So the hippocampus is an area of the brain that's responsible for memory, and it's also capable of something called neurogenesis. It's one of the few places in the brain where you can form new neurons. Okay, important to know. But the excitotoxicity, and that's what we think causes the brain damage here, the excitotoxicity in the hippocampus can actually be detrimental and in some cases has been associated with depression. I'm going to tackle another big one here for you guys, which is the risk of substance use in those prescribed stimulants. So this comes up all the time. And you know what most psychiatrists will tell you? They're going to tell you that the risk of substance use disorder does not increase with stimulant medication treatment. In fact, it's the exact opposite, right? It reduces the risk of substance use disorders when ADHD is treated appropriately. Okay, fair enough. This is the prevailing theory. This is what people have said. This is what I've been taught in residency. This is what's been said by many, many doctors. However, when we actually look at randomized controlled trial data and not retrospective data or observational data, when we look at real randomized controlled trials, which is the highest level of evidence that we have, and there was one really good one that actually looked at delinquent behaviors and emerging substance use in medication-treated children. So they looked at a group of children, they followed them over time in a randomized controlled trial setting, and they were looking for changes in behavior, evidence of delinquency, as well as evidence of substance use disorder. Now, what the authors found and concluded was that there was significantly higher rates of substance use in the stimulant-treated individuals. So people who were on stimulant medication had higher rates of substance use. And the conclusion by Molina, who's the lead author on this study, was we need to reevaluate the risk for substance use disorder as children age and when they are prescribed stimulants. So as children age and when they're prescribed stimulants, we need to be aware of the possibility that addiction can be higher, that rates of substance use can be higher in these populations. Now, I know what you're going to say, correlation does not equal causation, but this should give us some pause at least when we're thinking about blindly stating things such as there is no risk for addiction with stimulant use. Clearly there is, and again, our high level of evidence, randomized controlled trials, tell us and inform us that we should be more concerned about this than we actually are, because most doctors, like I said, are not. So most of the people who are saying, again, that there's no risk for increased substance use with stimulant treatment, and in fact it goes down, that claim is based off of observational data and not randomized controlled trial data, so it's not the highest level of evidence. Let's wrap this topic up here with a little conclusion. So, what can we say about this discussion? ADHD diagnosis is not as simple as checking the boxes off for the diagnostic criteria. Psychiatry has had a tendency to just keep adding diagnoses to patients' chart to justify prescribing practices. So the doctor is not fully engaging the patient and understanding, the mood disorder components and everything else. They're just saying, well, not only do you meet, criteria for bipolar disorder or major depressive disorder, you also meet criteria for ADHD, therefore we have to treat you for both because these are comorbid disorders, not ever taking pause and considering the fact that maybe these are all just parts of other disorders. These are symptoms associated with poorly treated bipolar illness, poorly treated major depressive disorder. So we should be looking for other possible explanations for ADHD symptoms, including the possibility that this might just be a normal variation of behavior. This is a normal variant, nothing to do. Before prescribing in the adult populations, you want to consider the person's temperament. Again, is this just normal? Is this within the range of normal? You want to consider comorbid mood disorders such as bipolar and depression. You want to look at possible secondary gain, like improved performance, and also substance use disorders. Some people might be asking to be prescribed stimulants just because they are stimulant users and have in the past been addicted to things like methamphetamine. You have to really be careful when prescribing these medications. Now, I'm not saying that there is no place for ADHD medication. Obviously, in children who are delayed, as I discussed in the neurobiology section, in terms of prefrontal cortex development, they may be useful. The important part is that we reassess them regularly and that you stop the medication once they've caught up with their peers and the symptoms remit or decrease to levels that other interventions can be used in place of medication. So that's my take on ADHD, guys. If you liked the video, please subscribe to the channel. It really helps me to keep this thing going. And I'm going to come up with new material next week and we'll talk about another interesting topic. So thanks for watching.